Hello, my name is Sharon Walmsley. I am a professor of medicine at the University of Toronto in Canada, and I'm a clinician researcher who deals with HIV. And I've had a special interest in managing HIV infected women. Uh, Today, I wanted to talk a little bit about the significant advances that we've had in the prevention of maternal to child transmission of HIV. But obviously, in order for us to prevent a woman from passing HIV to her newborn, it is important that the woman knows about her HIV status. And therefore, many parts of both the developed and the developing world have developed strategies whereby women are tested for HIV at their first perinatal visit so that information can become available for the optimal management of the woman. Now, HIV can be transmitted to a baby during in utero development, at the time of delivery, or after birth by the means of breastfeeding. The vast majority of that transmission, however, does occur at the time of labor and delivery. And therefore, the biggest or the most important approach to prevention of maternal child transmission is putting the woman on effective antiretroviral therapy such that the amount of virus in her blood at the time of delivery is what we call below the level of detection. And if we are able to do that, then the risk of transmitting the virus to her baby during labor and delivery is almost zero. So prior to the use of anti-HIV treatment, the risk of that transmission was somewhere of the order of 20 to 40%. When we used to use a single drug like AZT for the prevention of maternal child transmission, we were able to decrease that risk to about 25%. And now with combination antiretroviral therapy, that risk is practically zero, if not less. And strategies for the use of combination antiretroviral therapy have occurred not only in the developing world, the developed world, but also the developing world as well, such that maternal to child transmission rates are decreasing very dramatically. The other approaches that might be made is that a woman may be offered a cesarean section at the time of delivery so that if her virus is not completely controlled through antiretroviral drugs, or if she presents late in pregnancy, that may be another option that is offered. The last concern is that HIV may be transmitted through breast milk. So in those countries in which formula feeds is an affordable alternative, it is generally recommended that HIV-infected women don't breastfeed their babies and use formula feeds. In many parts of the developing world, however, those formula feeds may not be available or affordable, and therefore the woman may need to breastfeed in order to ensure the adequate nutrition of her child and also to prevent many of the diarrheal illnesses and other things that occur in those countries. So in that circumstances, studies have now shown that if the mother is on effective antiretroviral therapy and the baby is also on effective antiretroviral therapy, that again, the risk of transmission through breast milk can be markedly reduced. So when we approach women living with HIV who wish to become pregnant, we have to make sure that we design an optimal therapy for her that will be safe, that will decrease the virus in her blood, thereby decreasing the risk of transmission to baby. We also need to make sure that we choose those drugs for which we have the best knowledge so that we do not cause any harm to her unborn child. So we're optimizing maternal health, reducing the risk of maternal child transmission, and minimizing any risk to her unborn baby. And with these realities, we have now been able to allow many women living with HIV to have uninfected children, and that being HIV infected is not such a stigma to her becoming pregnant as it had been in the past. I thank you.